going to demonstrate a unique technique of managing acute corneal hydrops in keratoconus patients. None of the authors have any financial disclosures to make. Keratoconus is a disease of the eye in which cornea becomes thin and ectatic, and in advanced stages corneal hydrops develops. Acute corneal hydrops is a condition characterized by stromal edema due to imbibition of aqueous through a tear in Descemet's membrane. The predisposing factors are VKC, the younger patients, and Down syndrome patients. Conservative management aims at providing symptomatic relief to the patients. It includes topical steroids and antibiotic eye drops and hypertonic saline eye drops to reduce the corneal edema. Intracameral injection of non-expansile perfluoropropane and sulfur hexafluoride is practiced worldwide with good results. But the main limitation with this method is the time taken for complete recovery of corneal edema, which is more than 3 months in most of the cases. In a study published by Basu et al., they have found that the mean time for complete resolution in C3F8 group was 78 days, and it took 117 days in patients managed conservatively. As most of these patients are very young and to be visually handicapped for a period of around 3 months is a huge burden of their lifestyle. This was a corneal photograph of an 18-year-old girl who presented 4 years back with a history of sudden blurring of vision along with significant corneal edema. Patient gave a history of gas injection elsewhere 3 months back, but there was no improvement in the visual acuity. To know the cause of persistent edema, an anti-segment OCT was done and the culprit found. This cleft at Descemet's level was responsible for persistent corneal edema. As gas injection had already been done, I went ahead and planned the double tamponade technique for this case. Double tamponade means one tamponade is given at Descemet's membrane level with intracameral gas, and second tamponade by full thickness sutures, which holds the detached Descemet membrane along with posterior stromal surface, as well as squeezes out the accumulated fluid in the stroma. Preoperative pilocarpine eye drops instilled to constrict the pupil to avoid intraoperative damage to clear crystalline lens. After making the side port, non-expansile perfluoropropane gas is injected full chamber. Then full thickness sutures are passed perpendicular to the cleft direction, which can be identified clinically or on anti-segment OCT. 10-0 nylon sutures are used for the suturing. Sutures should be very tight intraoperatively, otherwise on post-op day 1, sutures will be loose and won't serve the desired purpose. Knots should be buried and banded contact lenses placed on top of it. Make sure that gas bubble is moving inside the anterior chamber to avoid pupil block post-operatively and increasing intraocular pressure. Post-operatively, strict supine position is to be maintained for 1 to 2 days. Pupil should be pharmacologically dilated. Antibiotic and steroid eye drops should be given until gas bubble resolves. Sutures are removed at 3 weeks. On post-op ASOCT, there is no detached Descemet's membrane seen. Cornea is compact clinically with suture marks visible, which fades away over time. Cornea is lustrous, compact, with no scars visible. This was another case of acute corneal hydrops with large cleft. The double tamponade technique used to treat it. On post-op day 1, corneal edema resolved almost by 70% and visual recovery started taking place. At post-op 3 weeks on suture removal, this is the clinical picture. No corneal edema, no cleft, and good visual recovery. This was another case of corneal hydrops, same technique used, and on post-op day 1, almost 90% of corneal edema resolved. This double tamponade technique works wonderfully in the management of corneal hydrops. Outcomes of different methods were evaluated. In group 1, patients were managed conservatively without any intervention. In Group 2, intracameral injection of C3F8 gas alone was done. In Group 3, double tamponade technique was employed. In terms of corneal edema recovery time, it was 7 days in double tamponade group, around 75 days in C3F8 group, and around 100 days if managed conservatively. Along with faster resolution of corneal edema, this technique also improves the best corrected visual acuity because switching flattens the cornea. Many hydrops patients managed with double tamponade technique are maintaining good visual acuity, and none of these patients required keratoplasty till now. The longest follow-up is of 4 years. In conclusion, this technique is simple and effective. It helps in faster resolution of corneal edema, early visual recovery and rehabilitation, and it improves quality of life of the patient significantly. Thank you.